Topic of lecture: symptoms and methods of diagnosis of pulpitis. First, about classification. There are two classifications of pulpitis. The first one is International Classification of Diseases, ICD, and according to this classification, all forms of diseases of pulp and periapical tissue has code K04. Pulpitis, all forms has code K04.0, and there are some other codes for the each forms of pulpitis. Initial pulpitis hyperemia has K04.00, acute pulpitis K04.001, purulent or pulpal abscess has code K04.02, chronic pulpitis K04.03, chronic ulcerous pulpitis K04.04, and chronic hyperplastic pulpitis or polyp has code K04.05. As for other codes, these diseases like necrosis of pulp, degeneration, denticles are not very common, very popular, and so these codes not for study, not for remembering. There is another classification. It is clinical classification of pulpitis by Platonov. According to this classification, all forms of pulpitis are divided in three groups. First one is acute, the second one chronic, and the third one is exacerbation of chronic. And acute has two clinical forms, local and diffuse. And also there is matches, they match to classification ICD. Local matches K04.01 and diffuse to K04.02. Chronic pulpitis has three clinical forms, fibrous, gangrenous, and hypertrophic, and they also matches to classification by ICD International. Fibrous 3, gangrenous 4, and hypertrophic 5. And exacerbation of chronic pulpitis matches the same code like chronic, because the most often form which may be in exacerbation curves is fibrous, so the same code. Recognize pulpitis itself is not very difficult, but it is difficult to determine which form of the disease is present in patient. Symptoms of inflammation of the pulp, periapical tissues, and periodontium have a certain similarity, which makes the diagnosis more confusing. The main symptom of pulpitis is a toothache or pain, and when we start gather complaints and anamnesis, we find out this main symptom, pain, and we start asking patient some additional question. For example, what problem is, does it hurt to cold or hold, when, for example, chewing, when it starts, and so on. To make an accurate diagnosis, dentists are guided by the type of manifestation of pain, and it may be pain or without pain, or the fact of the presence of pain, yes or no. Next characteristic is causality or reason, and according to this classification, pain may be spontaneous or causal. Spontaneous without reason, causal from reason. Next, duration. It may be short-term or long-term. Next, intensity. Very strong, acute, and not very strong, aching. Next point, the presence of or absence of light gaps. Irradiation pain is given in some places like ear, neck or head, and its development in time. As for features of pulpitis pain, depending on its type, there may be spontaneous or acute, or less often causal or chronic. It may be paroxysmal, characteristic of acute forms, localized also for acute, and irradiating also for acute and purulent. Intensive and attacks of pain of a growing nature, pulsating and prolonged. It characterized for purulent. Interview also includes anamnesis. During the survey, the doctor finds out the history or course of life and disease. So there are anamnesis of life and anamnesis of disease, as well as the general being of the patient. Anamnesis of life is necessary to determine the factors that can contribute to the development of pulpitis. The survey allows to present an approximate course of development of a pathological condition in a particular patient. Next, we move to objective methods. They confirm and clarify the diagnosis, and depending on the form of pulpitis and the nature of its cause, treatment is prescribed. And there is several methods, and they are also divided in several groups. As for main methods, there are inspection, probing, percussion and palpation, and also survey. And as for additional, thermometry, electrodontodiagnostic and radiography. And step by steps about these methods. Inspection. There is general inspection and local inspection. General is assessment of general status. It may be satisfactory or unsatisfactory, caused by pain, poor sleep, loss of appetite. As for local status, we search and inspect of the caries cavity. Caries cavity may be easy to detect. We can see this cavity like this. And another option, opposite option, when caries cavity is difficult to detect, it is called hidden caries cavity. For example, when it is in, in proximal surfaces in contact on the tooth. So we use some additional methods like angle probing with curved tip, semi-quantity for comparative percussion, and thermal cold or hot tests, and of course radiography. Next method is probing. Probing, the aims of probing are depth, pain, status of bottom. As for depth, in pulpitis is most often deep caries cavity. Pain may be sharply painful, and as for options of bottom, there are some options. It may be dense when horn of the pulp is not opened, and softened when horn of the pulp is covered with a loose dentin, or the horn of the pulp is opened. As for percussion, we use semi-quantitative or comparative percussion, depending on response on its result. It may be painless when no response from patient doesn't feel anything, painless. Weakly painful when patient feels something, not strong pain, but some symptoms. The tooth understudy is different from a healthy one, and it may be painful when patient feels pain strongly, clearly. Percussion is clear and sharply painful. And the next result is sharp pain. The tooth hurt even when touched with the tool or tongue. In pulpitis, percussion more often painless and less often weakly painful. Next method, it is from additional group, is cold test, thermal test. It may be cold or hot. When cold test, we use cold water, ice, or some aerosol freons like chlorophyll with the temperature minus 25 degrees. And its characteristics. For example, no pain when no response from patient. It's not characteristic for pulpitis. Short-term pain, it's for caries, not in pulpitis. Pain with a long-term or trace pain, it's for pulpitis. And testing causes an attack of pain, it's also for pulpitis and especially for acute forms. And another type of thermal test is heat test. We use hot water, heated instrument, or heated gutta percha, and heat test with pulpitis causes a pain attack or trace pain. And as for evaluation of thermal test result, there is 4 distinct responses. If no response, it may be non-vital pulp or false negative. If mild response, all normal, all intact teeth, give us mild response, not very strong but still. If strong but brief, it's a reversible form of disease like caries or initial pulpitis. And if strong but prolonged reaction, it's irreversible form like almost all forms of pulpitis, acute, diffuse, and all chronic forms. Next method from additional group is Electroodontodiagnosis, EOD. It's the technique based on the fact that diseased and healthy pulp tissue have different electrical excitability. Healthy nerve responds with pain sensation to the effect of current intensity of 2 till 6 microampere. Fibrous pulpitis responds to 35 till 50 microamperes, and gangrenous requires exposure in 60 to 90 microamperes. There are some factors that may influence reading. They are teeth with large restoration, teeth with more than one canal. Dying pulp can produce a variety of responses, weakness of the tooth during testing, and, for example, batteries in the tester may be weak. And in this table there are some indicators characteristic of different pulp, of different form of diseases, and also as well as normal teeth. Normal front teeth give us result about 6 microamperes, and lateral teeth may be up to 20 microamperes. And for other forms of pulpitis, their own results. As for death of the entire pulp, for example in periodontitis, the result is more than 100 microamperes. The next method is radiodiagnosis. There is a radiological classification of caries cavity by depth. It is the same we studied in cariesology. There are 5 types of caries cavity, since K1 there is in the enamel but not deeper than half. K2 also is enamel but more than 1/2 of its depth. K3 in enamel and indenting till its half. K4 in the deep layers of dentin more than 1/2, and K5 deep indenting and penetrates into cavity, into pulp chamber. K4 is characteristic of acute form. Caries cavity is localized in the dentin, in the deep layers of dentin, but not without communication between caries cavity and pulp chamber. And for chronic forms of pulpitis, K5 cavity. In X-ray picture we can see K5 cavity because caries cavity penetrates into pulp chamber. There is communication with caries and pulp cavity. And after all methods of examination, we may make diagnosis or diagnostic conclusion. Normal pulp if or pulpitis when normal pulp. There are no subjective symptoms or objective signs. The pulp responds normally to sensory stimuli and a healthy layer of dentin surrounds the pulp. And opposite characteristic is pulpitis. There are some symptoms and objective signs and response from pulp, so we have to provide treatment. Diagnostic algorithm consists of several steps. First, localization. Next, character or nosology. The third one, course of disease, clinical form, and the mechanism. And according to these steps, we make diagnosis. As for localization, there is the number of tools, for example, 4, 7. As for character, it's the type, nosology, type of diseases. It may be pulpitis, it may be periodontitis, it may be caries, non-caries diseases. As for course, it may be chronic or acute or exacerbation. And the last one, clinical form. For chronic, there are 3 forms, fibrous, gangrenous, and hypertrophic. For periodontitis, there are some other forms, and we have to mention this exactly form. After examination, we may make 2 types of diagnosis. First one is preliminary diagnosis. It is before preparation and its purpose accurate determination of the affected tooth and the needs for its preparation. And only after preparation we may make the final diagnosis and its purpose to make a complete treatment plan with the choice of equipment, means, and materials. As for localization of the affected tooth, it may be based on patient complaints when patient detection of caries cavity or pain clearly localized in the tooth. For example, getting food in a certain place, painful bite on the causal teeth, or it may be a case when patient cannot clearly indicate the tooth. Detection caries cavity clinically and or radiographically. We also use semi-quantitative percussion, provocative test like thermal or cold, electroodontodiagnostic, and detection of irradiation zones. The next point after localization is character or nosology. What is it? Caries, pulpitis, periodontitis, or maybe not dental disease. To determine what you have to treat, you need to know the signs of pulpitis. and the main sign of pulpitis is pain. High limit of pain sensitivity of the pulp, especially in inflammation, is one of the most important characteristic of pulpitis. And also another one, after the termination of the stimulus, is a long trace of pain or there is an attack of pain. The next characteristic of pulpitis, not for all forms but still, is irradiation. Irradiation of pain is according to areas, special areas, which are called GET. When the pulp is irritated, severe prolonged pain occurs, and its reason is nearby cells of the cerebral cortex responsible for other organs are involved in this excitation. And according to this reason, areas of pain irradiation in pulpitis by Mikheva-Rubin. For upper teeth, there are some places, areas in face, in lip, in cheek, in front. And for molars, there is in the cheek and ear, and for the first molar in the temporary area. And areas for lower teeth, for molars, it's in the angle of mandibular. For third molars, it's maybe in the neck and also in the head, and for premolars is in the chin or even in incisors. The next characteristic or sign of pulpitis is periodicity of pain. The attack is followed by a light gap. Easy course of pulpitis, local. Pain attacks are short and light intervals are long. Short means from 5 till 20 minutes and light interval longer than 2 or 3 hours. And for severe running course of pulpitis, diffuse or purulent pulpitis, pain attacks are longer than 20 minutes and light intervals are shorter 1 hour and even shorter. Pulpitis can occur without pain, without subjective symptoms, like chronic forms, for example, chronic fibrous pulpitis, maybe without symptoms. The main condition for the diagnosis of pulpitis in complex clinical conditions is proof of the presence of live pulp. For example, pain of preparation, sensing, etc. special tests. And we also search bottom and find out its status. There are some options of bottom, and we do it after preparation. It may be dense. This is a symptom of caries, although it occurs with pulpitis, and it may be softened, threatening with opening of the tooth cavity. And the third one characteristic of the status of bottom is opened, the presence of communication between pulp and carious cavity, discovered until preparation, is an absolute symptom of pulpitis. And according its characteristic, there are tables which helps to differ some nosology, for example, caries, pulpitis, and periodontitis, according to some points, like status of bottom. In caries, status of pulp. In caries, it's live and healthy. In pulpitis, it's live and inflamed. And in periodontitis, it's dead. As for spontaneous pain, there is no spontaneous pain in caries. In caries, pain always after irritants from a reason, from hot, from sweet, from mechanical, from food. In pulpitis, it's maybe spontaneous pain, but sometimes for chronic fibrous pulpitis, it's also from reason. And when periodontitis, also spontaneous pain maybe. As for trace of pain or residual pain after removal of stimulus, in caries, no, pain is always short-term. In pulpitis, yes, pain is long-term. And in periodontitis, it's not characteristic for it because pain in periodontitis is constant. No, not from reason. And percussion, in caries, it's always painless. In pulpitis, it's more often painless, but sometimes slightly painful, for example, in acute diffuse pulpitis, purulent pulpitis, when some changes in periapical tissue occurs. And in periodontitis, it depends on curves. In chronic periodontitis, it's more often painless or slightly painful, but when acute or exacerbation of chronic periodontitis, it's always sharply painful. The next point of diagnostic algorithm is course of diseases. And it may be acute, chronic, and exacerbation. Chronic form may become acute, but it will not acute again, but exacerbation. For acute pulpitis, the main symptoms are spontaneous and causal pain. Attack provoked by stimuli are characterized by a pronounced intensity and duration in contrast to chronic forms. And nighttime pain also is characteristic of acute form. And its causes. The first one, the predominance in the body overnight nervus vagus, blood rush to the head and teeth in a horizontal position when sleeping, occurrence in the cortex of the center of excitation in the absence of other stimuli, and reduces blood circulation and showing down the metabolic process in the pulp and accumulation of metabolic products and pain-producing amines, biological active substances. For chronic pulpitis, little or asymptomatic process. Due to low reactivity, good protection of the pulp, sometimes it happens. A clear causal nature of pain from irritants. And after irritation of the tooth, there is a sharp pain with a residual pain or of less intensity than when acute pulpitis. For exacerbation of chronic pulpitis, spontaneous and nighttime pain, causal pain with more intense and prolonged attacks, and from history we find out acute pain in the past, a week maybe ago or more. For objective characteristic, the pulp horn is opened or covered with softening dentin. And also to differ course of diseases, acute, chronic, or exacerbation, it's maybe according to points, to some points. Cause of pain in acute, it without reason spontaneous, in chronic from reason causal, and when exacerbation, it's also spontaneous. Residual pain or trace prolonged pain. In acute, it's intensive. In chronic, it's weak. And in exacerbation, it's intensive. Duration. In acute, it's less than 7 days. And for local pulpitis, it's till 48 hours, till 2 days. For chronic, it's more than 7 days, and for exacerbation, it's more also. Objectively, we have to search bottom, and in acute pulpitis, horn of the pulp is not opened. In chronic, horn of the pulp is opened, as well as is in exacerbation, but sometimes it may be covered with softened dentin. The next characteristic is clinical form. In acute pulpitis, we have two clinical forms, local and diffuse, and in chronic course, we have three clinical forms, fibrous, gangrenous, and hypertrophic. For acute local pulpitis, it's the easiest form of acute pulpitis and characterized with spontaneous pain by not so high intensity compared with diffuse pulpitis. And the signs of acute local pulpitis, pain attacks are short, from 5 till 20 minutes, and light intervals, period without pain, are long, maybe 2 or 3 hours. And for the total duration, it's less than 48 hours, less than 2 days. For acute diffuse pulpitis, pain attacks become longer than 20 minutes, and it may be 20-30 minutes, and pain-free or light intervals becomes shorter than 2 hours and maybe than 1 hour. There are pains from hot and possibly weakly painful percussion. As for total duration, it's more than 48 hours, more than 2 days. To differ these two forms, local and diffuse, we also have to count this characteristic. Pain attacks for local short attacks, short time, from 5 till 20 minutes, and for diffuse more than 20 minutes. Pain-free without pain intervals for local from 2 to 3 hours, and for diffuse less than 2 hours and then maybe than 1 hour. Cause of pain, provocative factor for local, it's more often cold. For diffuse, it's hot. Hot is stronger irritant for the inflamed pulp, and when diffuse pulpitis, entire pulp is inflamed, and to provoke pain attack, we have to use strongest irritant like hot, for example. Duration in local less than 2 days, and for diffuse more than 2 days. Probing is local, is painful in one point close to pulp horn, and in diffuse pulpitis it's painful all over the bottom because all pulp is affected. Percussion in local is painless, in diffuse may be painless and may be slightly painful because of initial changes in the periapical tissue. Pathological anatomy in acute form. When local pulpitis, there is serous inflammation, microabscesses in the pulp, and as for periapical changes, periapical inflammatory reaction, it's absent. For diffuse pulpitis, purulent inflammation in the pulp, also microabscesses, but in the whole, in the entire of pulp, and some initial serous inflammation in the periapical tissue present. initial inflammation in periapical. For chronic pulpitis, it may develop from acute pulpitis in the presence of outflow from the tooth cavity due to its opening. It may be primary chronic when it's developed from deep caries without communication, and typically for its staging transition from one form to another and one side orientation. More favorable forms become unfavorable. Microscopically, in chronic fibrous pulpitis, there is growth of fibrous connective tissue, thickness and hyalinization of fiber, the decrease in the cellular composition, formation of petrification, and in the root pulp, similar changes are less pronounced than in the crown pulp. And macroscopically, we can see these changes. Pulp color, instead of cherry red, becomes pink or pale pink due to fibrous tissue, growing of fibrous tissue. The bottom retains its continuity. It consists of softening dentin. If it's removed, the opening of the pulp cavity in one or two points will occur. When chronic gangrenous pulpitis, microscopically, there is necrotization of the pulp, of the crown pulp, which is separated from the left pulp with granulation roll, and the root pulp stays alive. And macroscopically, we can see it. The color of the pulp becomes dirty gray due to decay, due to its necrotization, and caries cavity is widely communicated with the pulp cavity. For chronic hypertrophic pulpitis, granulation tissue is actively growing and goes outside of the pulp cavity through the perforation hole to the caries cavity formed by the plus tissue. The rest of the pulp is subjected to non-specific changes: fibrosis, petrification, and formation of denticles. And to differ these three clinical forms, we have also count these points, like reaction to temperature. In fibrous, it's too cold. In gangrenous, it's too hot. And in hypertrophic, sometimes there is no reaction, but sometimes it's maybe weakly painful to cold. Reaction to mechanical factors. In fibrous, it's positive. There is, yes. In gangrenous, no reaction. And in hypertrophic, there is reaction due to growing pulp from the communication. And as for status of bottom, in fibrous, it's covered by the softening dentin, but communicate in one or two points. In gangrenous, it's wide opened and wide communication between caries cavity and pulp chamber. And in hypertrophic pulpitis, there is opened with plus tissue, it's pulp polyp. And probing. In fibrous pulpitis, it's painful in one or two points. In gangrenous, deep probing, only deep probing painful, but superficial probing is painless. And when hypertrophic pulpitis, probing may be painless, superficial, and weakly painful when we move our instrument, our tool, deeper in the polyp. And the last point of diagnostic algorithm is mechanism or the reason of development. And the mechanism may be cariogenic, when pulpitis develops from caries due to communication between caries and pulp chamber, or without communication due to activity of bacteria. It doesn't mention in diagnosis when we write it. Another mechanism is periodontal due to periodontal pocket. Traumatic, it's detailized and iatrogenic. And according to these points, we may make diagnosis, final diagnosis. Localization, 4.6 number of tooth. Character or nosology, for example, is pulpitis. Course of disease, it's acute. Clinical form, it's local, for example, and the mechanism, if it's not cardiogenic, it mentioned, for example, traumatic. If it's from caries, we just write pulpitis, acute, local, and number the tooth without pointed of mechanism cardiogenic. And the main purpose of diagnosis is to make a treatment plan, and about it we speak further. The lecture is over. Thank you for attention.